Hey folks, in today's segment we're going to be talking about and doing a little sketching of the menisci of the knee, the medial and lateral menisci. We're going to talk about the anatomy of the meniscus, the function of the meniscus, how one would injure the meniscus, how a patient might present, possible exam findings, and then treatment options for meniscus injuries. So I trust that you will find this information useful and helpful the next time you see a patient in the clinic that may have a meniscus tear. And let's get started.
What I want to do today is the menisci, which is plural, or the meniscus. All right, there are two menisci in each knee. If we're looking at a left knee here, anterior to posterior, over femur, tibia, fibula, patella. The menisci sit on each side of the joint. So we have our lateral meniscus and our medial meniscus. All right. If you're looking cross-sectionally, they look like triangles. If you're looking down on top of the tibia, so if you remove the tibia and you look straight down on top of it, the tibia looks something like this, and we'll say this is the lateral aspect. We'll have our fibula on that side. The menisci look like two C-shaped rings. The lateral meniscus being more of closer to being a closed C, but they look like C's. They are fibrocartilaginous material, or tissue, I'll say. Looking something like that. So this would be our medial meniscus. This would be our lateral meniscus. And again, this is our fibula here, so that's what makes this lateral and medial. What is the function of the menisci? So it has several functions. The primary function is it deepens the articular surface of the tibia, creating more stability in the knee in its articulation with the femur. So function is knee stability. Again, because it deepens tibia articulation. It also provides nutrients to the knee. So it helps with nutrition of the knee. And they also aid in lubrication. All right, so that is the anatomy of the meniscus, or menisci, the function of the menisci. Now, meniscus injuries are quite common. So, injury to the meniscus, it's very common. We see medial meniscus injuries greater than lateral meniscus injuries, and a lot of the reason for that is 60% of our body weight goes through the medial column of the knee as opposed to 40% of the lateral. So we're putting more weight on that medial meniscus. What is a frequent mechanism of injury? So acute meniscus tears in younger populations is typically a result of an athletic injury, usually a twisting mechanism on a planted foot. And as we age, it is more common to develop degenerative meniscus tears. And that is more of just a wear and tear type injury, if you will. As we age, our tissues lose their water and resiliency, and that meniscus breaks down over time, especially if there's arthritic changes in the knee or wearing of the articular cartilage. And then, as I tell patients, it breaks down little by little over time, and then one day there's a straw that breaks the camel's back. It might not be anything dramatic, simply walking down the stairs or taking a step up, or stepping off of a curb, and you may or may not feel it. It just starts hurting, and it frequently hurts if there's a twisting of the foot or the knee, or a deep flexion type of activity. So degenerative tear occurs gradually over time. So what does a person look or sound like that has a meniscus tear? So a patient history. So typically a younger patient will have a mechanism for the injury. Again, usually a twisting type of injury. If it's an older person, there may not be a distinct mechanism, but patients will usually describe that have a traumatic tear. They will likely feel a pop or a crunch. That's how I've had it described in the past, and that's what I've felt in the past. Is I've had a couple of meniscus tears myself. So pop or crunch. Mine really felt more like a little crunch in the knee. So if it's a degenerative tear, they likely won't feel a crunch or pop. So degenerative, no pop. Now, if the tear is a big enough tear or an unstable tear that's moving and popping in the knee, they may have recurring popping. And that popping is generally painful. In a big enough tear that flips out of place and gets into the joint, there may be actual locking where the knee locks up. And true locking is where the knee is flexed, there's a pop, that meniscus tear flips out of place into the joint, and the patient cannot extend the knee. That is true locking. A patient not wanting to bend the knee because it hurts, that's not locking, but they may describe it as locking. Again, I've had meniscus tears, I've had a displaced, I've had a locked knee, and there's no mistaking that. So they may feel recurring pop or may not if the tear is not unstable. Pain is the most frequent indicator, and it's usually a unilateral sided pain of the knee. If it's a medial meniscus tear, that would be along the medial or inner aspect of the knee. If it's a lateral meniscus tear, pain would be along the lateral aspect of the knee. But they may also describe posterior pain. Frequently, tears occur in the posterior aspect of the menisci, and if that be the case, they may just describe posterior knee pain. So pain can be along the collateral aspects of the knee or posterior. If it's an acute injury, then they may not want to weight bear, so they may or may not be weight bearing. If it's a degenerative tear that's occurred over time, they may be able to weight bear just fine, just with pain. So those are presenting symptoms that they may describe. They may also have swelling, particularly if it's swelling or effusion, particularly if it's a lateral meniscus tear. Those tend to cause more of an effusion than medial tears. So what would the exam be like? Well, there is no great physical exam test for a meniscus tear, but the key indicators, or what makes you or makes me quite suspicious of a meniscus tear in a person that has a history for it, is joint line tenderness, and a positive McMurray's test. Now there are numerous variations of McMurray's. If I'm not mistaken, the original description of the test involves flexion of the knee. At the same time, you're rotating the tibia internally and externally with one hand, and the other hand with the fingers in the joint lines of the knee, and you're feeling for a pop, a painful pop. And having a painful pop was a true positive. If there was no pop, then it wasn't technically a positive test. But in actuality, in my experience, I've more times than not do not feel a pop, but I've caused numerous patients to jump off the table because it hurt bad enough. So from an exam standpoint, the go-to suspicion creators are joint line tenderness and McMurray's, especially if there's a history suspicious of the meniscus tear. One other test that you'll frequently come across is Apley's compression and distraction test. I'm not going to get too much into that, but essentially you're trying to do the same thing as a McMurray. You're trying to compress the meniscus and grind on it with flexion and rotation. But for this test, the patient is prone, lying on their belly. You have the knee flexed to 90 degrees. You're pressing down on the foot towards an axial load on the lower leg, and then you're maximally internally and externally rotating it, trying to recreate the pain. If they have a positive compression test, then you want to proceed with doing the distraction test, where you're lifting up from the ankle, holding the thigh to the table, and you're rotating, and you're looking to see if that relieves the pain because you're relieving that pressure off of the meniscus. So that's the other test, which I rarely do that one. So let's say we've got the patient, we've got their history, the exam, we're suspicious of a meniscus tear. What next? Well, x-rays are always a good thing. Not that you will see a meniscus tear on the x-rays, but you want to make sure that you're not missing anything, no fractures. In an older person, you want to look to see if there's any significant arthritic changes, because that can change what you're going to do about it. So you won't see the meniscus, but you want to look for arthritic changes. You look for joint space narrowing and osteophytes in particular. So after imaging, we're still suspicious of meniscus tear. So what do we do next, treatment-wise? So if it's a younger patient, we suspect meniscus tear, there's no arthritis on the x-ray, we're going to get an MRI and refer to ortho for possible surgery. If is it an older patient that we suspect of a degenerative tear, with or without arthritic changes on x-ray, you can basically treat this as if it were arthritis to start with. And that can be with relative rest, rice. Compressive wrap may help, or compressive sleeve. NSAIDs or non-opioid analgesics. You may even want to consider an intra-articular cortisone injection. And then if this person does not get better after those treatment efforts, then you can consider getting MRI and referral to ortho. But if a patient has arthritic changes on x-ray, arthroscopic intervention for meniscus tear is very suspect as whether or not they're going to get any long-lasting relief. So be careful with getting up hopes for significant relief with from a meniscus tear in the presence of arthritis from an arthroscopy. So that briefly sums up meniscus anatomy, function, history of a person with an injury to a meniscus, the exam findings of meniscus, and our treatment options. So I hope you found that helpful.
All right, folks, that wraps up our little segment on the meniscus and meniscus injuries. It's a very common injury that I have no doubt you will see in your clinic, and I trust that you have found this video useful and will be helpful the next time you see that patient. So again, thank you very much for viewing. If you have found this helpful, I would be very grateful if you would click subscribe down here in the bottom, or view other videos up here in the corners. So can't wait to put out another video for you. We'll see you next time.